So yeah, so welcome to the study group. Who would like to go next?
I'm Mattia, I'm a PGY3, currently at NUSC in South Carolina. And I've been joining these sessions that Eziosa has been hosting almost from the start. They've been great. Fortunately, residency keeps me busy, so I cannot be at each of these, but it's been great fun. Yeah, thanks for hosting these.
Well, thanks for leading this session, and thanks for being a big part of the group. Who's next?
I can go next.
Hi, good to see you
Hi.
again.
Oh, thank you so much. I hope you all are good. I'm on my way home. As you can see in the background, I'm actually in the store. But yeah, but I'm on my way home. I didn't want to miss this part, really. That's why. And yeah, I graduated from medical school last year. I'm an IMG. I'm now in Canada.
Nice.
And preparing for residency exams. Yeah.
Awesome. Congrats.
Yeah.
I'm currently at the mechanic because my car wanted this, start having some troubles. So, but it's all good. So I get it.
Yeah.
You learn when you can while you can. So awesome.
Yeah, exactly.
Good to have you here.
Thank you so much. I'll be turning off my camera because I'll be walking around so that I wouldn't distract you.
Sure.
Then when I'm home, but I'll be listening. I'm here. Yeah.
Sure.
All right.
Who would like to go next? Okay, if anyone else wants to go, feel free to introduce yourself. So I'm just going to share my screen and jump right into it. Can y'all see my screen? Everybody see my screen?
Yeah, we can.
Awesome. Let me do this slideshow. So, welcome to Ziengbe study session. Today we're going to be talking about myelopathy, and thank you guys for coming. And today's study session is sponsored by TrueLearn. So we want to give them thanks for sponsoring our study session. So for people who don't know what TrueLearn is, they are a neurology, well, actually, they are a test bank company, and they offer a lot of different test banks. And so here is their homepage. And, for those of us who are studying for different kinds of medical exams, they pretty much have different kinds. I think for the people that attend these study groups, we're probably going to be either preparing for the USMLE or the Neurology, Right, and board exam. So for those who are in medical school, you're probably going to be taking the step 1, step 2, and this is really good. I haven't seen other test banks that really offer the shelf exam, and looking in hindsight, I definitely would have considered looking into some of these test banks that offer shelf exams related to, the different rotations that we go through. So here's a company that actually, offers that. And then for the residents and, here, they offer the Neurology Right, which I am actually currently using the Neurology Right test bank. And they also offer the board exam. And this is for individuals who have already taken the boards and kind of want to get recertified. And so I'm going to go through and kind of show you what, the question looks like. So I think in med school, it's sometimes, there's certain test banks they get used, but then when we get to residency, no one really talks about what test banks we should be using. And in hindsight, now, I'm a 4th year. I wish I would have started using the test bank a lot earlier in my career, because then it, helps kind of guide the studying. So here's a question on epilepsy, talking about, you have someone who's in status. What are some of the treatment options? And, they just kind of go through, vagal nerve stimulation. So just kind of wanted to show you guys what the platform looks like. This is something you can go online. You can use it online. I have the app on my phone that I use when I'm, going from patient to patient or have some downtime. Good thing about this test bank is that it not only does it explain the right answer, it gives you a really good chart that you can incorporate into your studies. And so here they're talking about high yield information for vagal nerve stimulators. So now I can study this and know it high yield for the right and for the board exam. And then they also have some really good illustrations, and they explain why the right answer is right and also why the wrong answer is wrong. And they also give references, which is really helpful when you go and you're studying for your exams. So again, when you're looking for different test banks, make sure you look at TrueLearn. It's something that I use and I would highly recommend. And with that, we will get to talking about myelopathy. Take it away.
Thank you. So let me see if I can share my screen. Oh, there we go. Share screen.
I just made you co-host.
Perfect. All right. So I guess you guys can see the screen, correct?
Nice. Yes.
So let's start by, I'll open the floor. I have my own presentation here, but I guess I'll open the floor and hear whether anyone is confused about the term myelopathy, because I know that as a medical student, I was a little bit confused by this term, and then slowly not as confused. But does anyone have an idea of what we mean by myelopathy?
I will say I was confused of what myelopathy was until residency, and I started seeing patients with myelopathy. It's this like nebulous, cool term, because in neurology we love our terms, but it's sometimes kind of as a learner hard to be like, hey, so what does this really mean? So yeah, it definitely was a confusing term. So I'm glad that you're talking about it.
Yeah, so it's usually, when we talk about myelopathy, we mean something bad, some badness happening to the spinal cord, right? And there's different kinds of myelopathy. And so in and of itself, we mean something wrong with the spinal cord, right? Myel, white matter, so that's where myelin is also the same suffix. So I figured that before really talking about everything that can go wrong with the spinal cord, we'll talk about the anatomy. And I will also say that whenever we think about something going on with the spinal cord, something that always comes to mind, or a disorder that always comes to mind, is transverse myelitis, right? And I think a lot of times people throw in the term transverse myelitis sort of reflexively because it's so common. And instead, I've grown through the years of residency to really like the term myelopathy is a general term. There are some symptoms and some signs that are typical for myelopathy, and we'll go into that detail. But I will say that in and of itself, whenever I see a patient who has some, complaining of some tingling and some numbness, and he's complaining some bladder problems, and he's complaining of something going on with the bowel, it's always good to think about that something could be going on with the spinal cord. And I feel like there are a number of scenarios where we encounter myelopathy as a differential consideration, right? One extreme of the spectrum is a car accident, a traffic accident, someone that suddenly becomes paraplegic, suddenly becomes unable to walk. And that's a really clear scenario where someone has had a transection of the spinal cord or some big problem with the spinal cord or some trauma of the spinal cord. And that's where it's obvious that we're dealing with a myelopathy. And there are some more subtle scenarios where we come to considering myelopathy as a consideration. In the office, we see a patient that seems to be having a neuropathy, is complaining of just some numbness and some tingling, but maybe these symptoms are unilateral, so it doesn't quite fit with the neuropathy, and then we have to think about the spinal cord. Or they're complaining of a tight band around the torso, or they're complaining about some back pain. In those scenarios, those are some more subtle scenarios where we need to make sure that there's not something going on with the spinal cord. And now that's where we need to ask more questions. And some good signs and some good symptoms, let's start with the symptoms of a spinal cord disease would be definitely neck pain, some back pain, bladder, bowel, and sexual dysfunction, very important to ask even in the office. And also asking them whether they feel a tight band around the trunk. We hear this in our MS patients. Some patients report this as this tight band. They describe it as an MS hug, a multiple sclerosis hug. I've definitely heard this term. And then some other symptoms to keep in mind are patients who have some trouble walking. And why do they have trouble walking? Well, some folks have pain. And that's neurogenic claudication. And now for the med students, maybe if we have some, does anyone know what two kinds of claudication we usually think about? And claudication is basically painful walking. Does anyone, can anyone venture a guess as to what two kinds of claudication we can think about?
It could be due to the vascular diseases.
Yeah.
Like giant cell arthritis, I guess it causes jaw claudication.
Mm-hmm. Yeah. So that's right. Jaw claudication is a good idea. And you're also right about vascular. Now I will say, I would keep you're absolutely right about the jaw. Now in this case, I'm talking more so about walking, but you're right. I think claudication from the Latin, it just means pain, if I'm not mistaken. But in general, when we think about vascular claudication or neurogenic claudication, we're mostly talking about walking, but you're right, you can also have jaw claudication. And you're also right about the vascular part. So usually with vascular claudication, folks will classically have something where they stop walking, and upon stopping walking, the pain goes away, and that's mostly sort of a demand ischemia. And it's mostly seen whenever they have peripheral arterial disease. And I think at least in Italian, and I forget if the same jargon exists in English, but we say at least in Italy that this is the sort of the shopping mall disorder, because folks who stop, especially older people, right, with peripheral artery disease or some other vascular risk factors, will stop frequently in the mall, and they will stop by different stores, mostly, or at least to some extent, to stop this demand ischemia, right? Because they stop in front of a window, or they stop in front of a store, and the demand goes away. So that's for peripheral arterial disease. But there's another kind of claudication, and that's the one we're talking about today, which is neurogenic claudication. And classically, this is due to spinal cord stenosis, and that's really the stenosis of the spinal cord due to progressive spondylosis. And classically, that pain is not so much improved by standing; it's improved by leaning forward, and that's a classic sign that we have all encountered, or you guys will encounter if you haven't yet, on some question bank, where the classic description is someone leaning forward, leaning toward the cart at the groceries, for instance.
I think it's
and that's because
something shopping cart.
Mhm.
Is it related to shopping cart? I guess I don't.
Correct, exactly. So you have a shopping cart and you're leaning forward, right? And the reason is that sort of relieves the spondylosis. You're exactly right, and gives more space for the cord, and in turn, more specifically, it gives more space in the foramina where the nerves are passing by. Which is really where the spondylosis is occurring. And this really, this neuroforaminal stenosis is the reason why these patients are complaining of pain. You're exactly right. And next up, we have sensory ataxia. Now, does anyone know what sensory ataxia is? And it's a confusing term. I know that some folks from the movement disorder, some movement disorder specialists don't quite like this term, mostly because ataxia is classically associated with cerebellar disease. But of course, we have different kinds of ataxia. And really, ataxia is an unsteadiness. And there are different kinds of ataxia, but by and large, we can say there are two kinds of ataxia. There's cerebellar ataxia and sensory ataxia. And whenever someone has difficulty walking, and we've ruled out that there's frank weakness, and we see difficulty walking, that's where we need to kind of understand whether this is a cerebellar problem or it's a sensory problem. And you may see sensory ataxia with any problem of the sensory of the sensory nervous system. More specifically, it's a problem of the dorsal columns. And again, you may see this in a variety of conditions. Really, anything that goes from the dorsal columns to your nerves. To your peripheral nerve, so you can get sensory ataxia with a very bad peripheral neuropathy, or you can get it with a myelopathy. And does anyone know what? And we're gonna discuss this in more detail, but what kind of myelopathy tends to affect the dorsal columns specifically? And there's different kinds, but there are a couple that are a really high yield for multiple exams and for clinical practice.
Combined degeneration, B12 deficiency.
Correct. Absolutely.
And I think also an infectious cause, syphilis, tabes dorsalis.
Yeah, absolutely. Absolutely. I agree with all those. Yeah, no, those are great thoughts. So tabes dorsalis, it's tertiary syphilis, and we'll look at the anatomy in a second, but it's dorsalis because it's dorsal, right? And it's not the only place that tertiary syphilis affects. Classically, it affects both the dorsal columns, but also the dorsal root ganglion, which is why they also tend to have a lot of pain. And that's exactly right. And then B12, right? So B12 is, I think you actually gave the right name of the pathology. Can you say that again?
Subacute combined degeneration, I guess.
Absolutely right. So, and why is it combined? What is it combining?
I guess it affects all the dorsal and lateral, I guess, afferent.
Yeah,
assembly.
correct. So, subacute combined degeneration, that's exactly right. So it affects the dorsal columns, it affects the lateral columns as well. And so it does pair, though, it does pair the spinothalamic tract. So that's an important diagnostic consideration to keep in mind. Now, another term that you may have heard is Myeloneuropathy. And it's also seen with B12 deficiency. And the reason why it's called the Myeloneuropathy is that B12 deficiency affects both the dorsal columns as well as causing a peripheral neuropathy, specifically a distal symmetric polyneuropathy. Do you guys remember what else? What's another deficiency that can cause exactly the same pathology? You may see it with folks using dentures, or at least back in the day you could. Now it's more common with bariatric surgery, also with some folks with some specific tube feeds. I've heard of this recently. It's copper deficiency. It's rarer, but it's also something to keep in mind. So going over the anatomy for a second here. So we have the we have our spinal cord here, and this is a cross section of the spinal cord, one that we may also see on our CT scans. And we have the dorsal columns here. The dorsal columns are part of a system that really connects the peripheral nerves, the sensory nerves, that travel through the dorsal root ganglion, if you can make believe, to see a dorsal root ganglion here, and then these nerves are carried through the dorsal columns. And there are two fasciculi. There is a fasciculus gracilis, which is the one that's from the legs. It's more medial, and then we have the other fasciculus cuneatus that's from the arms. And again, this is typically affected by disorders such as Friedreich's ataxia or subacute combined degeneration, most predominantly in tabes dorsalis as well. And then we also have here our lateral column that really hosts a variety of different tracts, but most important will be the lateral corticospinal tract. And then we have the ventral columns, which also host another important tract, which is again the anterior corticospinal tract, and a variety of other tracts such as the reticulospinal tract. And then it's important to know that all of what's outside is gonna be your white matter. Also, we have the spinothalamic tract that's also very important, and that tract then connects with your thalamus more cranially, and that is the tract that carries pain and temperature. Finally, within the center of our spinal cord, we are going to have two horns. So we have a dorsal horn and we have an anterior horn or a ventral horn. And the ventral horn is where your alpha motor neurons are housed. So in ALS, for instance, this is where your anterior horn cells or your alpha motor neurons will degenerate. So that's another important pathology to definitely keep in mind. Obviously, the dorsal horns will then house the fibers for sensory pathways that then will then be housed within the dorsal columns and the spinothalamic tract. Now, going to our exam now, we've talked about our symptoms. Let's talk about some signs. So whenever we're approaching a patient who may have a myelopathy, it's important to keep in mind that there will be some important signs such as spasticity. It's very common for patients with severe myelopathy to have a specific pattern of gait, and the specific pattern of gait will be circumduction. And that is really due to spasticity. So whenever we feel the muscles, we will appreciate that they're tight. I like this term because it's a very simple term to keep in mind. And I like it as, or you can call it hypertonia or hypertonus if you want to be more formal. But I like to keep tightness in mind to then discern whether we're talking about rigidity, which is something that would involve a movement disorder, and more so the basal ganglion, the extrapyramidal tracts, and keep that separate from spasticity. Now, does anyone know, this is definitely more for the math students, but does anyone know how to distinguish spasticity from rigidity? So the main difference is that whenever we deal with spasticity, we have something called the cleft knife sign. or a cleft knife pattern of hypertonia. And this term comes from the thought that if you try to move a joint slowly, a joint that's spastic slowly, it'll move. But then if you try to increase the speed at which you're moving the joint, it'll catch. And the reason, or I guess the formal way to think about it is that there is a velocity-dependent increase in tone. And that's the hallmark of spasticity. Some other important signs to keep in mind are hyperreflexia. And hyperreflexia is really defined as, it's always funny because I don't know about some of the more senior residents here, some more of the senior neurologists here, but I always thought, at least at the start, it was kind of hard for me to really get a gestalt on this term hyperreflexia, because sometimes I would have a patient that's brisk, but nobody agreed that it was true hyperreflexia. And I formed my own gestalt now, but I feel like a good way to think about it, if you want to be sure that that's true hyperreflexia, is first of all, whether it spreads across a joint. So whether the movement you're expecting is not only brisker, but also that it spreads across a joint. And then the other thing to keep in mind is kind of keeping in mind the age of the patient. I feel like if you have very anxious 18-year-old and the reflexes are a bit brisker, but they don't spread across the joint, that's probably not hyperreflexia. If you have a 70-year-old person who may have neuropathy, may have multiple things, and they're brisk, well, that should give you pause, right? And that should then prompt you to investigate a bit more closely. And an additional thing that I'll say about this is looking for nearby signs. So if you see an isolated finding, try to find more evidence, right? And that's where the Hoffman sign comes into mind. And then cross-adductor responses and Babinski. And does anyone know what we mean by Hoffman sign and cross adductors?
I guess we check, we touch the one of the nail of fingers and look at the thumb if it gets abduction, the Hoffman sign.
Correct. Yeah, that's exactly right. And it's interesting because there's so if you flick the thumb downward especially with your nail, I think you should be at least a bit forceful. I remember seeing one of my stroke attendings do a Hoffman. I'm like, okay, I'm way too weak on how I do it, and I kind of changed the way I do it now. But there's also another one that I usually don't do just because I find a bit confusing, but a Schermner, which is basically the Hoffman done in reverse. Cross-adductor is another good sign to keep in mind, and one that's really easy to get objective data on, which is you're tapping one patella and the opposite leg will, or the opposite thigh, I guess, will adduct. I think we are all familiar though with upgoing plantar response, or the Babinski sign. And then also something that I increasingly appreciated over time is a pyramidal pattern of weakness, right? So weakness of the extensors of the upper extremities and of the flexors of the lower extremities. And I've kind of realized a bit too late that an easy way to remember this without having to remember each single muscle is to actually say that E for the uppers, F for the lowers, is in sort of alphabetical order. And I realized it late in my second year, and I had a facepalm moment that it could have been so much easier to just remember it that way. But in addition to that, another couple of things to keep in mind are definitely keeping in mind that another pyramidal sign is the pronation, right? Pronator drift of the upper extremities. That's also helpful, although I feel like it's a bit more helpful for stroke, if anything, for the reason that I think thoracic myelopathies are a bit more common, with some exceptions, though, because we definitely see cervical myelopathies in multiple sclerosis, right? So that's another disorder where pyramidal weakness is helpful. Clonus also helpful, which is basically a reflex where you see, I think especially with the ankle, you see spontaneous repetitive oscillatory movement upon flexing the ankle joint. Although you may, first of all, you may see clonus with any joint. Although I feel like patellar clonus is really only seen in serotonin syndrome, maybe very bad myelopathies, but I cannot say that I've seen it in myelopathy and patellar clonus. I will also say, though, you may get clonus upon testing your reflexes, and that's the definition of a 4+ reflex, right? Now, obviously, paraparesis and quadriparesis, I remember seeing a couple of stroke consults, actually, in the stroke codes. I think 2 come to mind recently, where the patient was suddenly unable to walk, a stroke code was called, but there was nothing going on with the face, nothing going on with the upper extremities, and it was a myelopathy. So in a way, well, sure, it wasn't a stroke, but it was the right call to call an emergency, and it's absolutely fine, you know, that the neurologist comes and we activate neurosurgery, and the patient was seen by them, and we helped out too. So it's something to keep in mind. I will also say that myelopathies, whenever you see a sudden onset weakness of half of the body, and then you go and you think it's a stroke and you don't see anything with the face, and the MRI is negative, you're not done. You're not done. And I think myelopathy is a good thing to keep in mind. Definitely, it's come up time and time again on the stroke service. Then something called the inverted bicep brachioradialis supinator reflex, where basically one becomes the other, which is basically a variety of the of spreading. This is my understanding. Correct me if I'm wrong. And then involvement of multiple contiguous dermatome.
That's interesting.
Go ahead.
This is the first time me hearing about the inverted biceps brachioradialis. So what happens? So if you hit the biceps, then you get the brachioradialis reflex. Is that what you're saying?
Yeah. So let me just read it out. So testing of the biceps, so brachioradialis reflex may lead to finger flexion instead of flexion of the elbow from loss of the biceps jerks and the brachioradialis, and spread to the finger flexors. So basically you have loss
so it's like you hit
the biceps.
So it's like you hit the biceps and the fingers flex.
Correct.
Interesting.
So it's sort of spreading. So I think what's going on, if my understanding is correct about this, my understanding is that you're losing the local level, but you have hyperexcitation of the lower level. Which is why you get sort of the spreading and suppression of the local level, which I think is sort of like the same thing. Yeah, and I think it's the same thing that goes on whenever you have, let's say, going back to the prior slide, right? I think that something that we frequently forget is that we always think about stuff that goes on in the spinal cord as leading to hyperreflexia, but really the reason why it leads to hyperreflexia is that the whole reflex circuitry is stimulated. It's sort of an upper motor neuron problem. But obviously, the spinal cord is not just upper motor neurons, it also has lower motor neurons here, which is why there's a number of conditions where you can get flaccidity with myelopathy. And a good example of that is poliomyelitis, definitely acute flaccid myelitis that we see mostly in kids. I don't know that I've seen a single case in an adult, although there's something in the literature, and then MOG as well. The caveat of that, and obviously, I mean, goes without saying, you get this with ALS as well. A caveat about this, or an additional thing to think about though, is that in the hyperacute phase, all myelopathies will lead to something called spinal shock, which is different than neurogenic shock. But what we mean by spinal shock is that in the acute phase, the patient will be flaccid, and that's due to the hyperacute moment. So I would say if you're suspecting an acute myelopathy or a hyperacute myelopathy from a patient that has fallen, then and you don't see increased reflexes, I wouldn't necessarily rule out myelopathy. If anything, in that case, I would test two things. And again, everyone who has had experience with this, please chime in. And I'd love to hear your experiences, but I feel like time and time again, the more I go through residency, the more I try to get an idea of the tone in all hyperacute fractions. And then I've sort of made a habit whenever the patient is going into the scan to at least get an idea of the Babinski. And the reason is that the Babinski tends to be the first reflex that's present. And it may be absent, and I will not do much with it. Or the toes may be downgoing. Again, I wouldn't do much with it. But an asymmetric Babinski or a Babinski is sort of some added data that I kind of would like to add to my gestalt in the acute phase. I don't know if some of the residents on the call have had experience with this, or.
For me, the Babinski is sometimes hard to differentiate from like withdrawal response.
Yeah.
Because sometimes, you know, for example, when I was previously in the MS clinic, I was like, oh, that person's toe is definitely upgoing. Then I'll go in with the attending and they'll say, oh, no, it was just, you know, a withdrawal response. So it's definitely, you know, the more Babinskis you do, or the more reflexes you do, the better it is. And so for me, one thing I'll, you know, share with especially the younger trainees is to do the full exam on as many patients as you can. Even like, for example, I'll get a patient, you know, that may present with a headache. And, you know, some people may, and it's not needed, may not do the complete, like all 4 different sensory modalities, but I try to make it a habit, if I have time, to just do the complete neuro exam outside of what's needed from a headache standpoint, because then that's how you know, practice and get that gestalt of, okay, this is hyperreflexic, this is normoreflexic, this is spastic versus rigid. Because it's one thing, you know, to sit and read it. It's another thing to really be able to call it when you see it on a patient. And the only way I've been able to at least pick it up is just practice. And then also getting the attendings to come with you and say, hey, look, can you come and look at this? Everybody gets busy, but I've tried to, especially for positive signs. Like if I have a patient's upgoing toes, I'm like, why is this patient's toes upgoing? And I'll get my senior attendant to be like, hey, can you just come look at this person's toes? So then I pick up, that's how I pick up, you know, different techniques and different styles. So I would encourage everyone to, you know, don't be afraid to be like, hey, attending, come and just do this with me. I just want to, because I think the beauty of neurology is that we really are probably one of the few specialties that still like treasure the physical exam, and it really does help guide our diagnostic workup.
Yeah, I completely agree. And I think I have a similar experience with the pronator drift. I don't know if you've had a similar experience with the pronator drift, but I feel like it's so important. First of all, it's such a powerful sign. But then it's so important to really get an idea for what's a convincing pronator drift and what's some random movement, right? Like you really want to be convinced about the fact that there is pronation and maybe there is a little bit of arm flexion, and then there is a downgoing movement, right? A real drift, because it's not uncommon for some folks just to drop the arm a little bit. We definitely see functional drift, which is another important sign to know about. We see levitation, an upgoing parietal drift, but it's important to know what's a pronator drift, what's someone just wobbling their arm, what's a diabetic patient, a bit of neuropathy and kind of ambling around, right? Because you definitely don't want to overcall, but it's important to test and see what normal folks do. And and you were saying, right, like a headache patient, they may have, first of all, they may be hiding some signs, but also it's important to know, well, this is someone who's completely stone cold normal. What's their exam, right? What are some idiosyncrasies that everyone has, right? And I will say that, yeah, I agree. I mean, a retraction response, there are some patients who have really obvious retraction responses where they're just moving their whole leg away, and you're like, okay, you're just retracting. But there are some folks that have something equivocal, right? So it's important to know what's equivocal, what's a really convincing Babinski, and it's hard some of the time. I mean, it's important to definitely get attendings on board and actually form your own opinion for what's convincing and what's not. Yeah, I completely agree. Well, really well said.
And another thing, now that I'm in the ED, I have to convince myself. If I see a sign that's positive, I do it. Like if I see an upgoing toe, I'll do it 5 times to convince myself, is this truly upgoing, or is just part of normal variation? So that's another thing that I recommend. If you see cross adductors, do it, like really prove to yourself that these adductors are cross, because when you write your note and things change, at least you can say, nope, I did it multiple times. That is truly a positive or negative finding. So that's one thing I've done that's kind of helped, and I've seen my seniors do it, and I picked up on that. They'll do the same, pertinent exam multiple times to convince themselves. Or if you feel that there's asymmetric weakness, do it multiple times and be like, is this patient truly weak, or is it more giveaway weakness?
Mm-hmm. Yeah, I agree. I've sort of found myself getting that from my seniors, and also now that I have a junior in service with me, I've kind of seen them do the exam, and I've seen myself do the exam, and I've noticed that when sometimes they have a doubt and they kind of feel a bit flustered about it and don't want to retest. And I found that whenever I have a doubt, I just keep going. I keep trying to get the patient to interact with me, and I think that's something important, because I don't know about you, but originally I felt a little bit self-conscious about having this patient do this maneuver multiple times. I wanna seem competent, but the truth of it is that you're the expert, and the patient is there because they have a problem, and they're grateful if you try to test something multiple times. And it's also important, a lot of these patients will have pain, and sometimes it's important to ask them, are you in pain right now? Can you give me an effort for even just a second? And really see if they have that 5 out of 5, because the truth of it is that no matter how deconditioned someone is, it's a different thing if they're encephalopathic or they're confused. But no matter how weak, no matter how deconditioned, or no matter how medically sick someone is, they should be able to give you a 5 out of 5 unless the nervous system is involved. So if they can give you a true effort, they should be able to give you a 5 out of 5 unless there's neurologic weakness. So it's important to really know, is this neurologic or is it not? And it can be tricky.
And because I agree, when I was first starting out, I felt self-conscious, like, oh, if I do it once and I get it wrong, and if I do it again, they're gonna know I'm an intern. They can see it on my forehead. And many patients are like, I'm here to get answers. And they're just all very thankful. They're like, oh my goodness, thank you for being so thorough. Like, thank you. No one has ever spent that long with the exam. So for them, it's like, oh, this person is really being very thorough. They're taking the time. They're not missing anything. So I haven't had anyone say, stop it. Unless they're in pain. But like you said, I try and tell them, I know you're in pain, but this will really help me figure out what's going on with you. So just bear with me. And 99% of the time they're understanding.
Yeah, absolutely. Yeah, couldn't say it myself.
This is giving me a great idea. We should probably later on down the road do like an entire session on the neuro exam, because there's, and kind of help, because I think the neuro exam is very intimidating. It was intimidating for me. And they just giving our tips and tricks. I'll write that down. That'd be a good topic to do down the road.
Absolutely. No, I'd love that. Yeah, no, absolutely. Because there's so much. I mean, I love going back to how it's taught, because it's always nice after you know it and you do it every day to see how it's taught. But it's so daunting for medical students, just even to memorize the whole thing, let alone to do it. So yeah, and it's funny because we have obviously start of the year now, so you have some new medical students coming along, and we're throwing to them things that are even advanced, because we're all excited, with bradykinesia and decrement and all that, which is like even more advanced. But so it's funny. It's important to have a good idea of what the normal exam is and what we look for. Going on to gait is super important. I think whenever you have a patient with a myelopathy, or whenever you have a patient with a neurologic disorder, it's so important to get a good gait. I mean, you're in the ED right now, right? And I think if they can, please, that's what I was taught, please have a patient walk, because that can always reveal unexpected things. You can get patients who seem weak and then they're able to walk when they're not really weak, or they may have something very selective neuropathy, maybe that's explaining the weakness. But if they can walk, probably most of their lower extremities is working reasonably well, with some exceptions. But in the case of myelopathy, if they can walk, and sometimes they cannot even move, but if they can walk, they may have stiff legs. They have something called circumduction, which is something that we see a lot with patients who've had a stroke, and it's basically where one limb does this little loop around the other one. It's kind of hard to explain, but basically the spastic limb will be extended because you have loss of flexor tone with the inverted foot, so they will have to sort of have to turn that spastic leg around the circle to avoid catching the foot. And then scissoring is another example, where another form of circumduction where both legs are spastic. So they have this scissoring movement where one leg goes around the loop, the other leg goes around. That maybe we can show a video in a little bit of this. And then finally, sensory ataxia. The Romberg sign, sort of like the pronator drift, is something that I think is very important to do. I feel like I was joking with one of my math students the other day that I feel like neurologists always say that it's important to know that the Romberg sign is not a cerebellar sign, but they've never heard anyone call the Romberg a cerebellar sign. So a Romberg sign, maybe someone wants to chime in and tell us what the Romberg test is and what the Romberg sign is. And if not, I can say that. So, and I think this is an important test for ataxia in general. So whenever we're testing for ataxia, we can ask the patient to stand up and look up. And the first step will be to have the patient look up, and that's not the Romberg sign. But if they can stand up with their feet together, and they're not wobbly, they can bring the 2 feet together, that rules out anything cerebellar, right? Someone who has a cerebellar disorder will stand with their feet wide open, their stance wide open, especially with the wide stance, especially if they have a hemispheric cerebellar problem, sorry, a vermal cerebellar problem. Hemispheric would be more so appendicular, this is more an axial problem. But if they can bring their feet together with their eye open, then probably their vermal cerebellum is doing fine. And we can then ask them to close their eyes. Now, someone with a sensory problem, no matter whether it's a peripheral nerve problem, no matter whether it's a myelopathy, it's a spinal cord disease, they will start to seriously wobble at that point. And that's if they have a sensory involvement. And that's because they're relying on the vestibular organs and their eyes to keep themselves steady. And remember, to keep steady, you need at least 2 out of 3. You need either your sensory organs to be working, your vestibular organs to be working, and or your eyes to be working, your visual system to be working. If more than 1 out of 3 fails, then you're in trouble. Now, I want to talk a little bit about spinal cord syndromes. And these are sort of the perfect syndromes that we don't always see. I think I think I've almost seen, yeah, I think I've almost seen all by this time in residency. Maybe not the perfect version of a Brown-Séquard, although something really, actually I've seen a Brown-Séquard. I've definitely seen an anterior cord syndrome. I've definitely seen a subacute combined degeneration. Now, central cord, I've sort of seen, but not really. So let's go over these. So let's look at the graph. This can be a little bit confusing, but they don't need to be confusing. So we can start with the Brown-Séquard. So Brown-Séquard is a hemisection of the spinal cord. And that's where you affect all your 3 systems, right? You affect your spinal thalamic tract, you affect your dorsal columns, and you also affect your lateral corticospinal tract. Now, an important thing to keep in mind is that your corticospinal tract, remember how the corticospinal tract goes. It goes from all the way from the precentral gyrus. It travels down through your coronary, your internal capsule. It goes through the corticospinal tract within the brainstem, and then the medulla, it crosses over. And then it travels to the lateral corticospinal tract, mostly ipsilaterally. And then finally it goes, it will synapse, and the neurons will synapse at the level of the anterior horn, and your alpha motor neuron will be here, and it'll go all the way to the muscles. So this will be an ipsilateral problem if you have a hemitransaction of the cord, a hemicord syndrome. So your ipsilateral muscles will be affected. By the same token, we're going to have the second tract that's affected our dorsal columns. And remember, our dorsal columns will travel peripherally. You have your peripheral nerve going into your dorsal root ganglion. And then that will end up traveling through the dorsal columns, and then remember the decussation here will occur again at the level of the cervical medullary junction, and so forth. So this will also end up being an ipsilateral process. On the other hand, your anterior spinal thalamic tract, again, the dorsal root ganglion will be at the ipsilateral level, but then it will decussate. So there will be a contralateral involvement. And remember, this that you this crossing over, this decussation will occur sort of 3 levels above. So there is something called a Lissauer tract. So the fibers themselves will go a couple of levels above. So there can be some minor ipsilateral pain and temperature loss, but by and large, with the Brown-Séquard, we'll have a dissociation of your vibration sense and perception to the pain and temperature. So pain and temperature will be affected on the contralateral hand body, whereas your motor, your strength, your power, and your vibration sense will be affected ipsilaterally. So same side. Important to keep in mind. For some reason, the original description of the Brown-Séquard was from bayonet wounds during World War I. So really neat transaction. It's a little bit harder to get a frank Brown-Séquard, but I've personally seen a traumatic Brown-Séquard. I've also heard from multiple co-residents, although I've never seen myself, that it can be seen with multiple sclerosis, mostly because multiple sclerosis will tend to affect more lateral structures. So you can get some version of a Brown-Séquard. I don't know about Espinosa, if you've come across a Brown-Séquard yourself, or it's been maybe common where you work. Or yeah, so if anyone
sorry,
has
you
seen
can't
it,
hear
by
me.
the way.
Oh, sorry.
Yeah.
Sorry, I have not seen a Brown-Séquard syndrome, but what I have seen is a like a spinal or anterior spinal cord infarct, causing the motor weakness and the spinal delayment weakness and sparing the dorsal columns.
Yeah, and that's, yeah, and I bet you've seen it in after a vascular procedure where you, because I remember being called on nights, first week of nights, being called as an emergency by the vascular surgeons. Is this, this happened during this, I think it was an aortic procedure. In my case, how did you come across that yourself?
For this one, it was an infarct. The patient had infarcted it was it was an ischemic clot, like atheroscleromatous clot. It wasn't secondary to a procedure.
Huh.
Yeah, which is very rare.
Yeah. Wow. Yeah, and because classically, at least, I've heard it mentioned in the setting of aortic procedures. But yeah, interesting that you would get it from a clot. I mean, it makes sense, of course, but yeah. And again, yeah, so with the anterior cord syndrome, you will get your both of the anterior motor, the anterior horns involved. So you get a weakness bilaterally, and then also the spinal thalamic tracts will be down. So loss of pain and temperature discrimination, but vibration is still preserved because the dorsal columns are supplied by 2 actually posterior spinal arteries, whereas there's only one, in most people at least, there's only one anterior spinal artery. And does anyone know what vessels the anterior spinal artery originates from?
Vertebral arteries.
Correct. Vertebral arteries, exactly right. Although there's a bunch of reticular arteries that then supply it during its course, and you have another bunch of arteries that supply it. But yeah, they do originate from the vertebral arteries. So you can also get it from dissection of the vertebral arteries, although it's a bit rare. Spinal cord syndrome, you can have You can have it in the setting of a syrinx, although you can also have it with trauma. And then with the syrinx, at least, go ahead. Thought someone was trying to talk, maybe not. Anyway, so with the syrinx, you have the central canal that becomes expanded. And then you can have, first of all, damage to the spinothalamic tract. So you can have some problems with pain and temperature. If it's from a syrinx, the upper extremities will be affected. So you have this sort of cape kind of pattern of loss. And these folks can burn themselves because they don't have any pain and temperature discrimination. I've seen a patient with a syrinx, although they didn't quite fit into this. They didn't really have a central cord syndrome, or I guess a variety of central cord syndrome, because they mostly had spasticity. So it was a thoracic syrinx, sort of a weird presentation. Again, that was sort of a weird presentation, mostly because motor syndromes should only occur later on, really only until the syrinx has expanded. So in that specific case, we didn't really know whether that was an incidental finding of someone having a syrinx. Combined degeneration, so we talked about it. So dorsal columns and spinothalamic tract involvement, and finally, can you guys hear me?
Yeah, we can hear you clearly.
Yeah, we can hear you. But sometimes
Sure.
going
But in any
in and
case,
out.
is it going in and out?
Yeah, but I think it's better now.
Okay.
Uh-oh. Oh, because something's probably going on with this internet. So let's see. For myelopathy, what else can I add on myelopathy? It's really good to know the differential or the different etiologies that can cause a myelopathy. Mattia, are you back?
Yeah.
Okay, go right
Yeah.
ahead. Or just fill in the space. Go ahead.
Yeah, I switched to the other line now. Hopefully it'll be better. Do let me know if there are any problems with my connection. So we're talking about subacute combined generation. We already talked.
You have to say you have to share your screen. We can't see your screen.
Oh, is it not shared?
Oh, let me make you co-host again. Maybe that. No, you still co-host.
Is it?
Awesome.
Is it sharing?
Yep.
Good. So subacute combined generation, we said dorsal columns and corticospinal tract. So mostly B12 deficiency and copper deficiency. I have a couple of slides on these anyways. So it's good to know these, keeping everything with a grain of salt, knowing that maybe these perfect forms will not be encountered. Some will be encountered. It's always rewarding when we see a perfect form, but sort of knowing at least the general idea can be really helpful in localizing these syndromes, these presentations. So I've come across this, and I think this is a really good way of doing a differential workup for myelopathy. And oh, by the way, I just wanted to give this book its due credit, because it's an amazing book that I really like. Clinical Neurology, Neuroanatomy, Localization-Based Approach by Aaron Berkowitz, a spectacular book. You know, it seems it's definitely good for med students, but you know, going toward the end of second year, I sort of moved to longer books. books, although now, looking back to the first chapters of this book, there's so much wisdom. You know, even I think even for more senior residents, there's so much wisdom in this book that some of the thoughts I've tried to find the same thoughts in other books, and I haven't really found it. Like the thought of thinking about the neurologic presentation as localization times time course. I really haven't found it in any other book. I was even looking through the Bradley, I was looking through Adam and Victor's, and I haven't really found it. And that seems to be almost I mean, every neurologist uses that thought in the Gestalt, but it's really crystallized in that book. So I definitely recommend it to all learners. I don't know if Eselza has used it, but
I haven't used it, but I am planning to get some copies from the author. I follow him on Twitter, and coincidentally this morning I had reached out to him because he's been PRing his book on Twitter, and I was like, oh, this would be such a great book to utilize in the study session. So I'm glad that you were able to screenshot some references, because I really definitely want to get my hands on it and incorporate it more into this study group, because he's a phenomenal educator. I follow a lot of his, you know, tutorials and podcasts that he has. Phenomenal educator. So yeah, I completely agree. I think this chart here is just so high yield. So when I go and I see patients, the first thing I'm like, what's the time course? Because then that helps me figure out the differential.
Yeah, no, I completely agree. So in thinking about the differential diagnosis of myelopathy, there's a number of ways to think about it. Well, the tricky part here is obviously you need to have thought about it, right? You need to have kept it in mind. So whenever you see someone who's weak or has a sensory problem, I would say keep spinal cord in the differential, and then you do your exam, obviously. You look for hyperreflexia, you look for a spinal level as well, which is sort of where you sort of poke the back and you try to see whether there's a clear level at which your sensation goes away. You can do it with anyone who has some numbness and tingling, and most of the time it will be negative and there's no myelopathy. But keep myelopathy in mind, because if you don't keep it in mind, you don't keep the whole pathway in mind, it'll never come to the differential until it's profound. But once you've entertained that there's a myelopathy, once you've localized to the spinal cord, then you really need to think about time course. Now, hyperacute myelopathy, a myelopathy that presents within 12 hours, it wasn't there, it's probably going to be sort of obvious there, especially if there's trauma, if there's a fall, and also if they are vascular, if it's a vascular presentation. Now, in anterior spinal artery infarction, we talked about it could be a clot, as we said. It could also be a vascular procedure. In the code that we got, I remember, or the urgent page that we got for someone who had just had this aortic procedure, the main question that the surgeons had was, is this an anterior spinal cord infarction versus is it an epidural hematoma? Because obviously those two will be approached very differently. And hematomyelia is the other one where there's bleeding into the spinal cord, of the spinal cord. So those are the hyperacute presentations. And then in the case of acute myelopathies, we really think about infections. Some here, you know, we talked about acute flaccid myelitis, which is an infection of the anterior horns, and then spinal epidural abscess. This can be tricky. You know, a septic patient who becomes weak, that's something that can fly under someone's radar, mostly because if someone's septic, that's where all of our efforts will go into, and sometimes you can just miss it. And I've never seen it myself. I've thought about it a bunch of times and never seen it myself. But I remember there was a really good tutorial a while ago by Casey Albin, but about a patient that they couldn't figure out that had a spinal epidural abscess, and kept going. So it's something, it's a scenario that's important to keep in mind. Schistosomiasis, never seen it, but apparently it causes an acute myelopathy. And then inflammation. Inflammation, I think, inflammation is something that we see so much of. Here in the South, we see a lot of sarcoid. We also see a lot of MS, NMO. So those are some MOG as well. MOG, I think, MOG can definitely cause myelitis. It can cause something also with a flaccid myelitis, with the H sign. Although MOG, I mostly think about, or I prevalently think about in patients with bilateral optic nerve, bilateral optic neuritis. And then lupus as well. Now in the subacute bucket, sort of more than 12 days to months, spondylotic myelopathy, so common, so easy to miss as well. Where your spondylosis becomes so bad that then it actually compresses the canal. Space occupying lesions. One of the board's favorite zebras, a Dural Av Fistula, where there is this fistula, arteriovenous fistula that grows and grows and grows and then compresses the spinal cord. We'll look at some imaging with regard to this in a bit. Neoplasias, also important to keep in mind. And then toxic metabolic, B12, copper. N2O toxicity, commonly seen these days. At least I've seen one case of this with whippets, where folks will sort of inhale nitrous as a recreational drug, and that can cause B12 deficiency.
Laughing gas, right? N2O.
Correct, yeah. And how they will, because classically we think about dentists. I don't know that dentists use laughing gas anymore. I have never come across it. Maybe with some specific procedures, but these days I've seen one case, but I've heard of plenty with as a recreational drug, really. So something to keep in mind. Vacuolar myelopathy. Does anyone know what vacuolar myelopathy is?
I do not.
Yeah, so this is again, never seen it myself, but it's an infectious myelopathy, mostly seen with HIV, advanced HIV, also seen with HTLV1, I want to say, and it's a disorder where the spinal cord basically vacuolizes, and the parts that are affected are the dorsal columns and also the anterior horns. Can be symmetric. And the other name for HTLV1 myelopathy is also tropical spastic paraparesis. I think now it has another name called HAM. I forget what HAM stands for, because I remember as a math student learning tropical spastic paraparesis, and there's another term for it. But if anyone remember the other term, I think HAM is probably for myelopathy, DM, but otherwise we can look it up later. And then chronic, right? So neurodegenerative, Friedreich's ataxia, basically because it's the same presentation as copper, Myeloneuropathy or B12 myeloneuropathy. In addition to that, though, actually no. So it causes something similar than that, but in addition to that, it also causes cerebellar disease. And what's a vitamin deficiency that completely mimics Friedreich's ataxia? Does anyone know? I think it's vitamin E deficiency. Then HSP, so hereditary spastic paraparesis, PLS, ALS, commonly seen, and also SCAs, so spinocerebellar ataxias, although in that case we have another constellation of symptoms. And just a brief word, SCAs and HSPs can have a lot of overlap, but those are I guess not necessarily rarer, but they're definitely in a different category to themselves. All right, so quick word on vascular myelopathies. There's a whole cadre of criteria here, but in general, spinal cord infarction, most common cause, anterior spinal artery infarction, can be due to thoracic, mostly in the thoracic spine, due to aortic aneurysm reconstruction or other procedure. You can also get with vertebral artery atherosclerosis, vertebral artery dissection, aortic dissection, syphilis, and then the MRI can be helpful. I remember in that case, we got a stat MRI. If you order an MRI, I don't know at your institution, but I didn't realize that if you're getting a spinal MRI, it doesn't come with DWI and ADC. You need to ask for DWI ADC. So that's something important to keep in mind. I'm not too sure why they don't put DWI ADC, but keep in mind also that especially in the hyperacute phase, great if you can get DWI ADC, but it's really grainy. Like spinal cord, to see DWI restriction on the spinal cord can be tricky. And the other sign is the owl eyes. Now, I think what's more important is to get a T2, although the T2 will not be present hyperacutely. So it's great if you can get an MRI quickly without destabilizing the patient with DWI, and maybe you get that sign, but this needs to be kept in mind, right? What am I trying to get? Do I really need to have evidence versus do I treat the patient accordingly? Do I just use my clinical acumen and treat the patient versus I go through a bunch of steps to get the scan and get the confirmation? Supportive is this intramedullary T2 hyper intense spinal cord lesion, which you can get later, right? As long as you rule out that there is a hematoma, which may change the management of the patient. At least this is my understanding. Please chime in if you have a different approach to this. So toxic metabolic, we talked about myeloneuropathy with B12 and copper. Whippets, we talked about vitamin E deficiency, cerebellar signs plus subacute combined degeneration. It's Friedreich's ataxia mimic. I've come across vitamin E deficiency once so far, and it was in the study of someone having multiple vitamin deficiency. So definitely there was some masking. I think in that case we had vitamin E deficiency, B12 deficiency, copper deficiency, thiamine deficiency. So it was really profound and really hard to know what was what. Beside the point too. Toxic myelopathy, heroin solvents, chemotherapies, and also conzo fluorosis. Conzo is a nutritional deficiency. My understanding is lathyrism is the other nutritional deficiency that can arise mostly in Asia and Africa. My understanding would be, and it's for lathyrism. I think it's a toxin within the cassava root, I think, but I may actually send out a line on this just to make sure.
I think I heard about it. Yeah, it's a disease common in Africa. I guess they eat kind of a root. Yeah, I heard about it, but I don't know exactly what it is.
It's cassava, isn't it? I think.
Yeah, it could be. I'm not sure.
Yeah. All right, neoplastic myelopathies. Now, this is another important topic to keep in mind. So, whenever thinking about the spinal cord, it's important to keep this division in mind. So, extradural, intradural, and intramedullary. More specifically, you may hear folks say extradural, which is outside of the dura. Now, this is a location where you can have metastases, most common in adults. You can also have meningiomas, the most common primary spinal tumor in adults. This is the same for brain tumors, by the way. Schwannoma and histiocytic tumors. And then we move to intradural intramedullary. So inside of the dura, and actually let's go with intradural and extramedullary. So inside of the dura, but outside of the spinal cord, outside of the medulla, although it's not the medulla oblongata, it's outside of the spinal cord. And that's where you have an ependymoma, astrocytoma, hemangioblastoma, and always metastases can occur. And then you have intradural intramedullary. Sorry, I mixed those two up. So intradural extramedullary would be neurofibroma, meningioma, schwannoma, and metastases. And the mnemonic for this, will be no more spinal mets. So neurofibroma, meningioma, schwannoma, and metastases. For intradural intramedullary, again, ependymoma, astrocytoma, hemangioblastoma, and metastases. I think this is a really neat mnemonic to keep in mind for intradural extramedullary presentations. We can then move to infectious myelopathies, and we sort of have the same subdivision. So with extramedullary infections, you can have arachnoiditis. This can be seen with syphilis, with TB, and then the SCA, right? Spinal epidural abscess, most commonly caused by Staph aureus. These patients would be sick, and then there can be some IV drug user or IV drug user infections, and then infections in patients with prolonged IV lines, Pseudomonas aeruginosa, coagulus, negative staph, and candida are possible presentations. Intramedullary phenomena. Now, going back to our subdivisions here, anterior horn, the anterior horn can be affected in acute flaccid myelitis. Way back in the day, there was poliomyelitis, really uncommon, at least in the West these days. We are trying to eradicate it completely, and it would classically cause an acute flaccid myelitis. Usually it would be, actually I spoke to one of my attendings from India, who was telling me that usually it's a monomyelic presentation, it's just one limb. Actually, I remember having an elementary school teacher way back when who had poly as a kid and still had a little bit of a limb, unfortunately, but was doing overall fine. Just the limb was affected. And more recently, enterovirus has been associated with acute flaccid myelitis, mostly in kids. I haven't seen a lot. I haven't seen any adults really, and they tend to come in epidemics. And then Myelo Radiculitis. Now this is the Ellsberg disease. And it's a rapidly progressive lumbosacral myelo radiculitis. So in addition to the myelopathy, we also have radiculitis. So these patients will be in pain. And CMV can cause a similar presentation. Leukomyelitis, so involvement of the lateral columns. You can have spastic paraparesis with HTLV1, dorsal columns and lateral columns, HIV, vacuolar myelopathy, and then dorsal columns in tabes dorsalis with dorsal root ganglion involvement, which will cause pain on top of that. Compressive myelopathy is important to keep in mind. Extradural, spondylotic myelopathy, so wear and tear and osteoarthritis of the vertebral column will cause this. Epidural lipomatosis, that's the sort of a board's favorite. And then intradural extramedullary arachnoid webs, chronic arachnoiditis and cysts, and intradural intramedullary our beloved syringomyelia, the syrinx we talked about in the central cord syndrome. And then we have a bunch of degenerative myelopathies, motor only with upper motor neuron signs, your PLS, your HSP, which are primary lateral sclerosis, which is the upper motor neuron version of ALS, upper motor neuron exclusive version of ALS, HSP, hereditary spastic paraparesis. And then for lower motor neuron only, spinal muscle atrophy, and then the combination of the two, which is really ALS. I think more and more, a lot of my mentors from neuromuscular are telling me that these exist on a spectrum. It's really a continuum, but these are the classic buckets we think of these in. Especially for HSP, which has a lot of its own genes now. And then motor and sensory, you have your spinocerebellar ataxias, PPMS, primary progressive multiple sclerosis, and a bunch of different leukodystrophies, mostly the adrenomyeloneuropathies. Although I think from these, PPMS, ALS are really important to keep in mind. I think the SCAs are becoming more and more common, especially if you're interested in movement disorders, especially now that we have so many panels and a lot of treatments also coming down the pike. So it's an exciting time for these. So I wanted to go over a few imaging pearls because I think these are always fun. So here we see the rabbit ear sign. So you see a little rabbit here with some imagination. This is a really good sign to keep in mind. So before jumping into this, actually, I wanted to spend a few words on imaging. And I think one of the things we all look for in imaging is how many segments it expands, right? How many segments do I see signal? How many segments does it go for? And if it's more than 3, we're talking about something called longitudinal extensive transverse myelitis, or myelopathy, I guess. And before jumping to this, I think it's also important to kind of address the elephant in the room, which is transverse myelitis. I think that's where we all jump to. And transverse myelitis, the definition by and large is a myelitis, so inflammation of the spinal cord that extends transversely, and technically it should be transversely across the whole thing, but then the term really became inflammation of a part of the spinal cord. And it's sort of synonymous with MS, although it's not all that transverse myelitis is MS. And there's also an entity called idiopathic transverse myelitis, which is transverse myelitis that we don't know, of which etiology we don't really know the cause. And I think it was at Mayo where they did a fantastic study that I recommend that anyone read, where they showed that following these patients over time, they really declared themselves. And a good proportion of them ended up having either spondylotic myelopathy or non-inflammatory myelopathy or some other cause, right? And we'll look at a few causes now, but I think that was a splendid, a fantastic study, really looking into the etiology and really showing that, well, just because you call it transverse myelitis, it doesn't need to be transverse, it doesn't need to be an inflammation. So that's where I really like the term myelopathy to take a step back. Any words on that? I think it was from Mayo where it was training. So if you guys have some additional words on your approach to this, I'd love to hear it.
Did it comment about the Flanagan or Zaleski or?
Yeah.
Okay, yeah, they're huge. Zaleski is a huge, and so is Flanagan. A huge autoimmune spinal MOG, MS, aquaportin 4 experts in the field. And so I just actually got done from their clinic and trying to tease out, when you have a T2 hyperintense signal in the spinal cord and it's spanning less than 3 segments, MS, but there's also others, that can span less than 3 segments versus an extensive longitudinal lesion? What's the differential, for that? And they're the ones that actually discovered the MOG antibody. And, going through that work and understanding how they came to that conclusion. So it's pretty cool to be able to work with some of these individuals who, made a huge, contribution to the field of myelopathy. And so they love their like owl sign versus missing pink, or versus pancake sign versus missing puzzle piece. And I'm sitting there like, I don't, the trident sign. So they coin all those signs, and I'm still trying to figure out, they must have been hungry when they came up with some of those signs. But yeah, it's pretty cool to work with some of them.
I bet. And, and that's exactly right. So, whenever it's spanning more than 3 segments, you call it a longitudinal extensive transverse myelitis, if you will. And we're really talking about T2 signal. I think two sequences that really like are your STIR, which really suppresses fat, which is actually, I think, short tau inversion recovery sequence, but it suppresses fat really good. And then whenever I scroll, I like having them side by side, even actually always when looking at the spinal cord, because looking at one in isolation is not really helpful. It can be. But
I'll be right back. You keep going. I'll be right back.
You got it. So having them side by side is really important. Having your axial and your sagittal. And so if it spans more than three segments, start thinking about something like NMOSD, neuromyelitis optica spectrum disease. And if it doesn't, MS is in the differential. Now, that being said, though, there's a bunch of other conditions that can cause longitudinal extensive myelopathies. And this is one of them. Now, this is not longitudinal extensive, but you can definitely see a longitudinal extensive signal change with B12 deficiency. And this is the sign, that's the classic sign, the rabbit ears. You'll definitely see in your lives. There's a lot of B12 deficiency going around. With fad diets, with folks having nutritional deficiencies, and this is the sign that you'll appreciate. So this is the dorsal columns, so think about that. And obviously, whenever approaching this, it's also important to kind of know the correlation with the history. So if it was a acute finding, does it enhance, right? If the patient is just having symptoms now, does this enhance? If it doesn't enhance, it's unlikely to really be inflammation. So consider B12 deficiency in the differential. And then this is the other sign where you can get, again, here you can get transverse, you can get longitudinal extensive enhancement, right? And you can have, longitudinal extensive T2 hyperintensity. And then if you give contrast, you may see this little ditzel here, this little focus of enhancement. But this is not inflammation. I remember actually having a discussion in radiology conference about this, and this is the pancake sign. It may not be there. It may not be there at all, but if it's there, it gives you further evidence that there is a spondylotic myelopathy going on. And this is a really neat finding. I remember being in radiology conference talking about this, where, is this, there was a discussion, is this inflammation? And the radiologist would say, no, this is not inflammation. This is just restriction of contrast within one level due to the compression of the spinal cord. And here you can appreciate compression of the spinal cord, compression of, there's no spinal fluid here, and hyperintensity below that level, and the pancake sign at the level of the compression. And this is a spondylotic myelopathy. Really important to keep in mind. And then this is just an angiography. Oh, this is, I know what I was trying to show here. So this is the flovoids that we may see with the spinal dural AV fistula. These are probably the most beautiful flovoids you'll ever see. And And this is again the AV fistula we talked about, but then you can definitely go for angio. I think there was a paper, I forget if it was a paper, it was someone telling me this, but someone was telling me about this patient that they really thought had spinal dural Av fistula. It fit with their exam, but everything came back negative, and then they ended up sending them for angio and proving their hypothesis. I can't say I've seen one of these in practice thus far.
I've
Have
seen
you
one.
seen one? Yeah.
Yeah,
What about the presentation?
and it was a very, very subtle. And I'm actually writing this up for a case report. So as soon as it's published, I will send it to you all. It was a 3-week gradual decline in, like a myelopathy type symptoms like bowel incontinence, like frank bowel incontinence. Like this is someone who never doctored, who did a lot of like outdoor work, big beefy, like, and then patient comes in and he's like, I'm having bowel incontinence, I'm having urinary incontinence, this is embarrassing, I can't, stay on my legs would give out. He said his legs would give out intermittently, he'd be falling, and we see him and the exam is complete, like it's the only myelopathy finding that we could pick up on, and I didn't pick up on it. It was one of my attendings who's just phenomenal with their neuro exam. There's maybe a very subtle left-sided foot drop, but extremely subtle. But he didn't have a spinal level. He didn't have frank weakness in isolated muscle testing. He did have like a peripheral, superimposed peripheral neuropathy, but he didn't have hyperreflexia. His toes were mute, didn't have clonus, no cross adductors, but because the history is what was like, okay, there's obviously something going on. So we just got complete spinal imaging, and to my surprise, I get an email from my attending saying, hey, look, check out this guy's imaging. He has a Dural Av Fistula. So we send him to neurosurgery and they do embolization, and his symptoms, have improved. And it's a very rare finding, but for him, it was even more rare because his exam did not match that of myelopathy, but his history did. So that really taught me history is so important in neurology. History will give you the answer if you listen closely. Because if I had just done his neuro exam, I would have been like, there's, nothing here, you're fine. But it was the history that gave us red flags.
Yeah. Wow. That's impressive. Yeah, they do send us the link to that because I'd love to read it. Yeah, it's fascinating. Yeah, I mean, we could do a whole other conversation about history, like history taking in neurology.
That's a really great idea. Yeah, I'll definitely put that on the lineup.
Yeah. Okay. Oh, and the allies. In the patient I told you about, we didn't have these beautiful eyes. I actually remember and this is for the spinal cord infarction. I remember we actually called neurosurgery. We were on the phone. This was like 3 a.m. Me, my senior back last year, and talking to our neurosurgery colleague. We're all on the phone and squinting, and then we pulled up a paper, like it kind of looks like it. Not this beautiful, but that proved our hypothesis, although our clinical exam also did. But yeah, it's always, I think a word of caution to all trainees is that you can see these signs, and sometimes you get beautiful signs, but also keep an open mind that you don't always, like whenever someone publishes something, they want the best picture for their sign. You don't always see something that blatant and then beautiful. So keep an open mind. This is the trident sign seen in sarcoidosis. We see a lot of sarcoidosis here in the south, and this is mostly the trident sign is mostly involvement of the PL, so PL involvement in sarcoidosis. This is a central canal lesion. And that's about it. That does it. I hope you guys enjoyed this.
That was phenomenal. so phenomenal.
Thank you.
That impressive. Thank you so much. Very
Thank you. It's
thorough.
my pleasure. It's a really, really interesting topic. I could have spoken about this for ages. I know you guys had done something with the spinal cord anatomy before, so I tried to stay as novel as I could here.
Thanks. I think it kind of ties in really well with, you know, some of the discussions we did earlier that was more on anatomy, and then you brought in the differential, the history, the physical exam. So just thank you for taking the time to do that. It was
And I love the discussion too. Yeah, sort of sharing our mutual experiences. Yeah.
cool. So with that, it's getting close to, well, it's 5 o'clock here in Central Standard Time. I'll keep you guys posted on, you know, the next study session, depending on, you know, people's schedules, and, you know, if you guys have topics you want to do. We're moving out of emergency neurology and ICU because we have done that for, you know, probably 4 or 5 months now. So it's basically, you know, open topics, whatever people are interested in, you know, just let me know, and then we'll, you know, get together and do this all over again.
Yeah, if folks are interested, then we had talked about a while ago, maybe doing something on vertigo. What are your thoughts about that?
Doing something
On vertigo?
Let's do it. Yeah, that'd be a great one. That would be really
capping our emergencies and then going into neuroanatomy.
Yeah, that'd be awesome. That would be, because I know that is a it's a difficult history to take. It's a difficult exam to perform. And, you know, it's one of those things that, like you said, you not only get it in the emergency room, but you also get patients that present, you know, I'm dizzy, I'm lightheaded, you know, room is spinning, and what's the differential for that? So yeah, that'd be a really good topic.
And that could be also a good segue into doing maybe history and physical the following time, and then we can go to anatomy.
Sure, great, yeah. I love it. Awesome. And if anyone has any additional comments or questions, you know, make sure, I think everyone here is on the WhatsApp, but if you're not, send me an email and I'll send you a link to the WhatsApp. And I think everyone here has already officially signed up on the website. And we'll keep the discussions going.
Oh, it was a fantastic presentation. Could you please provide the slides? So I want to do a review. It was a great, fantastic presentation.
Absolutely.
I really appreciate it. Thank you so much.
Yeah, my pleasure. Let me do it now.
Awesome.
And then also I saw a question about the name of the book. I'll write that down too.